So now we are going to start our Retina CME session. This is the second session, and we are just beginning the exciting and academically enriching session on the preferred practice pattern in retina diagnostics. We are truly privileged to have with us our eminent national guest faculties, Dr. Subina, Dr. Suganeshwari, Dr. Poornachandra B, Dr. Pratyusha Gane, who bring immense expertise and experience in the field of retina. What makes this even more special is that they are also the experts leading our PGs in the fishball session on retina and a highly interactive and dynamic learning platform. And I must say with great pride, this is the first ever PG fishbowl session by the Jharkhand Ophthalmological Society, and this is the brainchild of Dr. Shweta Walia, again one of my very close friend, CSC of and Madhya Pradesh State Society. I am confident that this focused priming on retina diagnostics will not only strengthen the fundamentals of our postgraduate students, but also empower them to actively engage, think critically, and derive maximum benefit from the upcoming fishbowl session on retina. So, and we have our JHOS office bearers with us, Dr. BP Kashyap, the past president of Jharkhand Ophthalmological Society and MC member. We have Dr. Rahul, our Suja Samanta, our secretary, Dr. Sunil Kumar, ARC chairman, then Dr. SP Jakhanwal, the president, Dr. Rahul Prasad is the joint secretary of JHOS, and he is the heading the VR unit of RIMS. Dr. Vibhuti Kashyap is the MC member from JHOS and member East Zone ARC AIOS. Dr. Archana Kumari is the head of Vitreoretina Surgery, Prasad Eye Hospital. Dr. Abhishek Patnaik, these are the chairpersons. Dr. Abhishek Patnaik is the VR consultant, Tata Main Hospital, Jamshedpur. Dr. Divya Prabha is the senior resident, Rio Rims Ranchi. I think they all have joined and respected the state platform. And Dr. Ritika is the VR consultant, Gita Shri Retina Institute, Ranchi. Dr. Divya Prabha, Dr. Ritika, are you here? Dr. Divya Prabha and Dr. Ritika, Dr. Abhishek Patnaik, Dr. Archana, have you joined? Dr. Rahul?
Yes, ma'am, I'm here.
Okay.
Dr. Archana is here, ma'am.
Okay. So, Dr. Abhishek, Dr. Divya Prabha, Dr. Ritika, because I have also to see that every time their photo is flashed on the flyers time and I'm circulating and they are not even taking half an hour time out. So Divya Prabha and Retina and Ritika are absent. Dr. Rahul, are you here? Because
yes, ma'am. I'm absolutely here. I've been here since the very beginning.
Yes, I can see.
Yeah, sir is there. We have been able to see him for quite some time. He's there. Sir is there.
And ma'am, congratulate you on the first session, ARC session. It was wonderful, ma'am.
And all because of this Doyle's wittiest mind. And so over to Dr. Rahul Prasad to introduce the eminent speakers. They are all national faculties and they are going to teach they have taken time out so from their busiest schedule. So please introduce them all so that one by one they will present. So Dr. Subina, Dr. Suganeshwari, all of them are such big people of retina, a star of international retina, rather, I will say.
Very good evening, ma'am. And it's my honor to introduce Dr. Subina Narang. She is a vitreoretinal specialist. She has a number of publications in her bag. She has done her fellowships. She has received a number of numerous awards in national and international conferences, including Nursing Rao Award 2011. She has been an honorary secretary of HICO 2021, Outstanding Ophthalmic Teacher of India from FOTI in 2023, and multiple travel grants. The post holds are member managing committee AIS from 2017 to 2020. She has also been the honorary secretary, Chandigarh Ophthalmic Society. Now, coming to our second guest, that is Dr. Suganeshwari Ganeshan. She is the Senior Consultant Professor of Ophthalmology. She is from Shankar Nethralaya, Vitreoretinal Service, Vitreoretina and the Oncology Services. She has done her vitreoretinal fellowship from Shankar Nethralaya. She again holds the position of leading intraocular oncology department of Shankar Nethralaya. She is the project director of Lions Skill Transfer Training Program. Her principal interests includes diabetic retinopathy, ocular oncology, and intraocular infection. She is a great academics, great reviewer. She has a number of she has been a guide to number of theses, trained 35 cataract surgeon across India in 2 months to diagnose, perform laser and intravitreal injection for diabetic retinopathy. She is a co-investigator in Dream's study, published more than 60 articles in peer-reviewed journals and 4 textbooks. She has served as a co-investigator in many international clinical trials related to diabetic retinopathy, choroidal neovascular membrane, and retinoblastoma. Slide, please. Of course, Dr. Poornachandra, he is a vitreoretinal consultant from Department of Electrophysiology and Clinical Genetics, Narang, Nethralaya. He has been associated with many Jharkhand academic activities for last couple of years. He has completed post-graduation from the prestigious AFMC Pune and followed by a long-term fellowship in vitreoretinal surgery from Narayana, Nethralaya, Bangalore. He has undergone additional training in inherited retinal disorders and electrophysiology from the most famous Moorfield Eye Hospital, London. He has completed his preparatory on age-related eye diseases from Safe Sight Institute, Sydney. Presented several papers on national and international forums, has published many articles in peer-reviewed journals, has won several awards, including Rima Mohan Award for Best Paper Retina at AIOS and Best of IGO Awards. His area of interest includes inherited retinal diseases, electrophysiology, retinal vascular diseases, and gene therapy. Welcome, Dr. Poornachandra. So, our next chairperson is Dr. Pratyusha Gani, and speaker is Dr. Pratyusha Gani. She has done her MBBS from BMCRI Bangalore and MS from JIPMA. She has done her long-term fellowship from Arvind Eye Hospital, and she is working as an additional professor at AIIMS Bangalore. European Vision and Eye Research Foundation Fellowship at Cardiff University 2014 she has completed. Medical Retina and Cataract Fellowships, which is sponsored by the Royal College of Ophthalmologists UK between 2015 and 2016. She has received her ROP training at LBPI Hyderabad in 2024. She has almost 60 PubMed indexed journals, publications, and she has also almost 4 chapters, book chapters, the presentation, numerous presentation at national and international conferences. Her area of interest include imaging in retinal diseases, diabetic retinopathy, and artificial intelligence in ophthalmology. I welcome Dr. Pratyusha. I mean, Dr. Divya is also over here, ma'am.
Yeah, I think some network issue is there. So I think sir, my voice is not audible.
Yeah, we're getting you, Divya.
Okay.
Ma'am, you're muted.
Dr. Ritika, are you here? Because this is a retina session. So now, Dr. Rahul, please, they should start.
Yes,
so with Subina, Dr. Subina, then Dr. Suganeshwari, then Dr. Poorna, and then Dr. Pratyusha.
So I'll request Dr. Subina to kindly start with a slideshow.
And what a national faculty we are having today for our postgraduate students.
Are my slides visible?
Yes, ma'am, it's visible, ma'am. It's visible.
All right. And I'm audible, right?
Yes, ma'am, you're audible.
Yes.
At the outset, I would like to thank Jharkhand Ophthalmological Society for having me over here on the topic, which is very dear to me, retinopathy of prematurity. The learning objective here would be, let's understand what is the big challenge we are facing, the infants who are at risk of ROP. Then what is the screening criteria in India, the classification of ROP, and the treatment of ROP, a brief overview I'll give, and follow up in cases of ROP. We must understand that India has the highest number of preterm babies, 3.5 million, and ROP is a potentially blinding disease for these immature retinal vessels. Preterms at risk of developing ROP are around 2 lakh, and of these, around 20,000 go on to develop treatment requiring ROP. Each baby requires repeated visits, and we are just handful of ophthalmologists who are trained to or who are interested in doing ROP. And all these babies have to be followed up till the time retina fully matures. So thus we want people to join hands in screening of these babies so that they can be referred at appropriate times. Now, who are the babies who are at risk of ROP? The Neonatology Forum of India gave the guidelines. They said all the babies with gestational age of less than 34 weeks and birth weight of less than 1750 grams. And this would increase to 36 weeks of gestational age and 2000 grams of birth weight in case risk factors are present for ROP. Apart from gestational age and birth weight, we have a whole lot of risk factors like multiple birth, outborn babies, respiratory distress syndrome, acidosis, PDA, etc., which could add on to the development of ROP. In our study, we found that double volume exchange transfusion was the single independent risk factor for development of ROP. Screening is fairly easy, can be done by anybody who's trained in retina. And this has to be, the baby has to be dilated with diluted phenylephrine and tropicamide. 2 drops have to be instilled, and at 20 minutes interval, wipe the excess because our skin also absorbs these drops, and these could be detrimental to the health of the baby if you are putting more drops. The only thing required is the eye speculum and wire vectis. Wire vectis is for globe rotation, and these babies have to be swaddled properly, and you should do your initial examination in NICU setting so that any kind of abnormal, because once you are depressing the eye in the beginning, as you learn ROP, you would need help of pediatrician in case some untoward incident happens. When to screen for ROP, it's a beautiful slogan given by Dr. Subhadra. 30 दिन रोशनी के, that means within the first 4 weeks of postnatal age, the baby should get the screening for ROP. If your neonate is less than 28 weeks of gestational age, birth weight less than 1200 grams, then we prepone everything by 2 to 3 weeks. The median age at detection of stage 1 ROP is roughly post-conceptual age of 34 weeks. And in fact, as I said, there are just handful of ophthalmologists who are trained to do ROP or who want to do ROP. Then what we are doing is that lots of NICU and SNCU nurses are trained to take pictures of these babies with RedCam, 3 Netra, and now we have even mobile loaded the cameras on the mobile phone. They can take at least 5 images should be taken, the center, the superior, inferior, temporal, and lateral, which would be sent for teleophthalmology. And then the documentation of ROP must be done. The extent of ROP should be documented as what zone of retina it is involving, and the severity is as for the disease of ROP. In fact, because of the medical legal implication of ROP, we must document whether the patient was dilated or not, and when does the patient come back again. We should give the date to the patient. Now, zone 1 ROP is with the disc at the center. You draw a circle twice, the radius is twice the distance between the disc and the macula. And the outer than this zone 1, you have 2 disc diameter area. This rim is posterior zone 2. And then from the nasal ora serrata, the rim temporal to out of zone 1 is zone 2. The temporal crescent which is left behind is zone 3. So we must know which zone of ROP are we dealing with, because that tells us whether the baby is to be treated or baby is to be referred at what interval. Now, in a busy setting, it is very difficult to say what is zone 1. The best is having a 28 diopter lens. If your disc is at the rim of the field of view, what you are seeing, whatever you are seeing is zone 1 ROP. And for stage, if you have a demarcation line between the vascular and avascular retina, this is stage 1. And if you do fluorescein angiography, you just see a hyperfluorescence flat demarcation line. The moment this line gets subvolume, it becomes stage 2 ROP. And on it is not that fluorescein angiography is essential to diagnose stage 2, but it is just showing you what exactly is happening. You have capillary tufts posterior to the ridge in stage 2 ROP. In stage 3, you have fibrovascular proliferation, which is in fact standing like a wall. So this is stage 3 ROP. And on fluorescein angiography, there's intense leakage. This is the time you have to treat these babies. Stage 4A is once the retina gets lifted up, it is not involving the macula, it is stage 4A. Stage 4A B will be when fold of the retina is involving the macula also, and macular detachment is there. Stage 5, these are the images taken from ICROP3 classification. And 5A is once the disc is visible, total retinal detachment. 5B, the disc is not visible, total retinal detachment. And in 5C, you have anterior segment changes. You have shallowing of anterior chamber, iridocorneal touch, which is stage 5C. Aggressive ROP is something which need not be missed. I mean, it is, you have to see very carefully. You have to pick, if you have such dilatation and tortuosity, you should not miss this flat neovascularization. If you see this flat neovascularization, they progress, they skip stages. They progress straight to stage 5. So these babies need not be missed. And this is here where anti-VEGF agents really work very well. Plus disease is very important. This is basically dilatation and tortuosity of vessels. Now, this also has undergone change in ICROP3 classification. Earlier, it was so much of dilatation and tortuosity in all 4 quadrants. In fact, pupillary rigidity could be there, vitreous haze could be there. Now, with ICROP3 classification, it is that plus disease is a continuum of diseases. I mean, continuum of pictures. It is not just full dilatation and tortuosity. It could be something which is more than normal. Then beyond that, you have pre-plus disease. Then still more tortuosity is plus disease. So, and this also gave us the concept of notch. The notch is once in the temporal part, in the middle, you see that there's notch. So this zone of ROP is the spherous zone, which is there. And here it is zone 1, secondary to the notch, which is present here. So once you have all this, you know that you have zones and stages. Now, what is the ROP you're going to treat? Type 1 ROP is the high risk pre-threshold ROP, which we treat. Here you see that all in red needs to be treated. So once you have plus disease, any stage you need to treat in zone 1. Stage 3, even without plus disease, you need to treat. They are high risk pre-threshold ROP. And in zone 2, if you have plus disease, stage 2 and 3 is what needs treatment. Others are low risk pre-threshold ROP, which you have to keep on close follow-up. In our study on fluorescein angiography, we found that if you have to predict which of the type 2 ROP are going to go on to type 1, that means treatment requiring ROP, it is the ones with delayed arterial filling and ones with popcorn lesions. They are the risk factors for progression of type 2 to type 1 ROP. The treatment of ROP has undergone major change. It started in 1986. It was cryo, which was done for the avascular retina, changed to laser treatment with ET-ROP when they were doing diode laser for their babies. We are doing, in fact, 532 nanometer laser only. You have to target the growth factor now. Now the trends have changed from laser or cryo to anti-VEGF agents. With the coming in of BEAT ROP trial in 2008, they said, yes, bevacizumab has good outcome as compared to laser. 0.625 milligram in 0.025 ml was what they had given. And you follow a safer strategy. That means use soft needle, antisepsis follow-up, close follow-up. You can go ahead with treating these babies with anti-VEGF injections, which are 1 millimeter from the limbus you inject, and ranibizumab, aflibercept have also come up for these treatments. But most of us are usually giving the combination of treatment. Now, this is a baby, ROP baby. The macula is hardly mature in this baby. Once you do FFA, it is very clear that macular vascularization has not developed. So you don't want to laser the avascular retina here. The macula will go away. So what you do is you go ahead with anti-VEGF, let these vessels grow. And once the macula has vascularized, you go ahead with lasering whatever avascular retina is left behind. That gives good visual outcome to these babies. When to call these babies again, just touching on, if it's just the avascular retina, zone 1, call them after 1 week, zone 2, call them in 2 weeks, zone 3, call them in 3 weeks. In case ROP has developed, then it is 1 to 2 weeks you need to see these babies. In case it is ROP in zone 3, you could go ahead with 3 weekly follow-up. Otherwise, they have to be seen in 1 to 2 weeks time. In case you've already treated the baby, if you've done laser treatment, then first examination is usually done 2 weeks to look for skip areas. After that, the patient can be on longer follow-up examinations because it's a lifelong follow-up. I'll just show you how it can affect later on also in life. But in case you have injected anti-VEGF agents, then these babies are on 1 to 2 weekly follow-up till the time the whole vascularization is complete. Recurrence is typically known in after these anti-VEGF agents, so we have to be on the lookout. In fact, 8 to 12 weeks after that injections, they do go ahead with the recurrence. So we have to identify that recurrence, which would be dilatation of vessels again, and you have to treat at that time. Now, this is one latest study which has come in 2026. It says that type 2 ROP go ahead with dexamethasone eye drop, which could decrease the progression of ROP. But we have to do, I have no experience with this. We still have to go ahead with this treatment. We have to explore it more. If surgical consultation are in case your ROP has not been treated in time, it has progressed to stage 4A, 4B, or 5, you go ahead with surgery and pass then plicata vitrectomy or lens sparing vitrectomy is what we do in these cases. Here, doing little is doing a lot. In these little eyes, you just have to cut the basic traction forces, ridge to ridge traction forces, ridge to lens or ridge to zonal traction forces have to be cut. Don't change hyaloid in these cases. You don't have to go ahead with, removal of the hyaloid. And these 4A, the results are very good. Stage 5 results are not as good. It is pretty dismal. But so we have to prevent the babies to go to stage 5. Follow-up of ROP is lifelong. It is not that I have treated, that's okay. It doesn't work like that. So this is, you go ahead, these babies are more at risk of myopia, strabismus. Babies not going to tell you, have to see whether the baby has refractive error or not. So they have to be initially 3 monthly examination, then 6 monthly, then yearly examination, lifelong is there. It is seen that vision-related quality of life in these children, even the parents, the quality of life is affected, and most field which impacts the vision-related quality of life is having strabismus, not just having glasses. It is the strabismus and amblyopia, which is bad for these parents. ROP requires dedication, precision, perseverance, patience, long-term and lifetime follow-up. Once you see these babies achieving a lot or being now they are, in fact, they are postgraduates also, you really feel great. They come back and tell you, well, their vision is saved. That's really gratifying. Increasing burden of ROP emphasizes the role of comprehensive ophthalmologists in screening of ROP, and treatment requiring ROP has to be referred well in time. Thank you. My special thanks to Dr. M.R. Dogra and Dr. Tracy, under whom I have been trained, and they are the stalwarts in the field. Thank you very much, sir, for giving me all the knowledge for ROP. Thank you.
Thank you, ma'am. That was an excellent way you described ROP. Ma'am, with your due, ma'am, I would just like to ask one thing, ma'am. Can you please share few tips for the beginners, especially the residents who are about to start ROP screening? What are the helpful tips, ma'am, from your side, your experience, you can share with us, ma'am?
It's the patience. In fact, I would say babies are the easiest to see. You wait, you just have to wait. The doll heads maneuver does the job many times. You may not even require the indenter or the wire vectors, because to begin with, we learned from Dr. Dogra. And we would say, okay, this is difficult. It's just you have to jump into the pool. The babies are very easy to examine. They really do not, you just have to wait. The baby moves the eye and you see. Temporal retina, try seeing temporal retina first, because that's the most important part. So I think you would just have to jump into it.
And ma'am, while beginning the learning, ma'am, which lens would you like to advise, ma'am? Is it the 20 diopter lens or straight away going with the 28 diopter lens?
I would say 28 diopters, because zone 1 is what you should not miss.
Yes, ma'am.
So 28, it's easy to say, well, it's zone 1. Otherwise, you'll keep on thinking maybe you missed that or something. So I started with 28 diopters, so that was good.
Okay, ma'am. Okay.
Yeah.
Thank you, ma'am. And any other questions from the panelists?
Good evening, ma'am. May I ask a question, sir?
Yes, Vatsalap, go ahead.
Ma'am, I just wanted to ask, how can we be sure that we are at the aura or we can see till the aura in a baby?
In the baby, once you rotate the eye, you see avascular, you see the demarcation line beautifully, and then you see the avascular retina.
लिख दी हुई
Right?
जिंदा हम दुनिया दिए थे
Hello?
Yes,
Oof.
ma'am. Yes, ma'am.
Aura, you would be able to see the aura. I mean, there's a differentiation.
Yeah,
And once with your while
can.
you're rotating, you do see
Leadership
those
हटा दीजिए.
processes and you make out like, well, this is the aura. What? And then after that, you see the ciliary body and all that stuff. I think it's easy. It shouldn't be a problem. You have to see it to believe it. Yeah.
Thank you, ma'am.
Thank you, ma'am.
Thank you, Vatsala. Any other questions from for ma'am?
Yeah, hello.
Yes,
Am I
yes, Divya.
audible?
Yes, Divya.
Very nice presentation, ma'am. So I would like to ask you a couple of questions. One is, so I was usually I have given only Avastin injection in ROP baby. So what is your experience as Rajumab as an intravitreal injection in cases of ROP babies? And do you repeat the injection? And if you do, then what is the interval between repeating the injection?
Nice question. I work in a government institute, so we do not use off-label drugs, though people are shifting because the recurrence rate is lesser with Avastin. So people are shifting to Avastin, but in our institute, we are stuck on ranibizumab. We still give ranibizumab for these babies, and the recurrence rate is more, but the advantage is that the recurrence occurs early when the baby is still coming back for follow-up, 8 to 12 weeks. So you do get to see the baby. Definitely, if the recurrence will be there, you'll pick it up. And I never repeat. Because I have seen if you, even with one injection, the rate of growth of vessels stalls tremendously. 2 injections, they are definitely to just go in posterior zone 2, they'll be stuck there. So I never repeat my injections, and I think the study will be coming out with the study that do not repeat the injection because they really stop the growth of these vessels. So I haven't repeated.
Okay, ma'am. Thank you so
If
much.
there's recurrence, I would laser, but I would not repeat.
Okay.
Yes, ma'am.
Okay. Thank you so much.
So please invite the next speaker, Dr.
Yes,
Rahul,
ma'am.
please.
Yes, ma'am. Thank you, ma'am. And our next speaker is Dr. Suganeshwari Gopal Swami, and she will be presenting her slide in OCTA and helping us understand the delicate factors with concern with OCTA. Suganeshwari, ma'am.
At the outset, am I audible?
Yes, ma'am, you are audible.
Yeah. Good evening to all of you. I would like to thank the Jharkhand Ophthalmic Society for providing me an opportunity to be in front of all of you. And I have just now heard the wonderful lecture, the leadership program, and it was excellent program, I must say, and a lot of learning for me too from that program. So is my slide visible? Can you all see my
Yes, ma'am.
PowerPoint?
Yes.
Yeah, okay. So I will begin my talk on OCT angiograph. And first thing is for all of us is to understand a little bit about the history itself. Why the history is important? Because see, there are certain things which has evolved over a period of time. And if we don't understand history, I don't think we'll be in anywhere in between. And we should owe credit to all the people who have been innovators and inventors. So what we understand is this OCT is got a much higher resolution than the ultrasound or even the MRI. David Huang showed that multiple A scans could be displayed as a false color or grayscale image, that is a B scan, demonstrating the first OCT image in 1991. So what we had started initially as a concept and now where we have evolved to the commercial OCTA, which actually came in 2014. So we are going to see what exactly are the principles. So the principles are simple. It is basically on the interference pattern. And there are, you can see what is the interference pattern which is there. And it is an A scan at every point. So there are multiple A scans put together. That becomes the B scan. Now, what you exactly see is the OCTA is actually, we are talking about the representation of retinal vessels, but they are basically not the retinal vessels. What we do actually see is the moving retinal blood vessels within a predetermined range. That is what is important. So when you have a predetermined range, within that, whatever we study, this is called the motion. So it displays in vivo retinal vasculature in a depth resolved fashion. So, and what exactly happens? You have segmentation of the volumetric data. which actually leads to the identification of the retinal capillary plexus. So now if you see, this is what I had discussed is on the, basically it is about the motion contrast. So what happens is when you go through an A scan, it kind of detects the pattern when it is there, when there is movement of the erythrocytes, that is what is happening. So now when you have within the artery, within the vein, so within the artery, you have some movement happening. Within the vein also there are corpuscles which are moving. So now when these movements are happening, every A scan, because each as A scan has got a time lag. So these are multiple A scans taken with a time lag. And when these A scans are processed, that is what comes as OCTA signals. So you have one at T, one at T1, one at T2. This is what is the multiple signals that are being generated. So now what are the slabs that we have? So you have the superficial capillary plexus slab, you have the deep capillary plexus, you have choriocapillaries, you have the choroid. And then what you also see is if in a, sometimes when you are having a very good eye with a clear media, you may be able to see the choroid and sclera interjunction. And you kind of have the default slabs, wherein there the most important one is the VR interface. If you're talking about proliferations, one should concentrate on the VR interface. And if you are talking about, let's say, about diabetic retinopathy, one should pay attention to the deep capillary plexus slab, because that is the first one to get affected, and even in a vein occlusion. Then you have the avascular complex, the choriocapillaries, and the choroid. So now, how do you exactly understand what are the layers that has been seen in the superficial capillary plexus? So you have the ILM, the GCL, the inner plexiform layer, and this is important for certain conditions, like what when you want to see an foveal avascular zone, you please pay attention to the superficial capillary plexus. When you have a proliferative diabetic retinopathy, then you pay attention to the SCP and in a vein occlusion as well. And what about the deep capillary plexus? So the deep capillary plexus, you see it in the inner nuclear layer and the outer plexiform layer. And this is the place where one has to pay attention when you want to see about the vascular laws in the diabetic retinopathy. And what about the VR interface? So now, avascular slab. When you talk about avascular slab, this is the most important layer when you're talking about choroidal neovascular membrane, or the type 3 MNV is predominantly seen in this slab. So in this, you basically see the OPL and the outer nuclear layer. And next, we have the choriocapillary. So when you want to study about the ischemia in the posterior uveitis, one should pay attention to the choriocapillary slab. And now we move on into the ORCC slab. So now the ORCC is the most important slab, because most of our patients who have neovascular membrane, choroidal neovascular membrane, or the type 1 MNP, you call it as, one has to pay attention to this slab. And so you are seeing the outer plexiform layer, the outer nuclear layer, and the choriocapillaries here. And what about the choroidal vessels? So the choroidal vessels are not clearly visualized. That is because the signals are blocked by the RPE and the overlying retinal layers. So this is one thing which you should kind of, predominantly we don't appreciate much of these things in this. And also we must understand with different machines being available, one should know which machine stands for what and when would you order. So when you're talking, I don't have any financial disclosure, though in Shankar Nethralaya, we have all the machines which is listed here available, but every machine has its own capacity. And I believe everybody can kind of study whatever machines you have. Using that, every disease can be studied well. That's what I should say. So if you are talking about a spectral domain OCT, you can have the Zeiss Cirrus, which is 5,000 or 6,000, wherein it usually performs around 68,000 scans, or the 100K, that is what. And you could get a 3x3 or a 6x6 or a 12x12. And if you are using a Zeiss Plexi Light, in this you get the maximum scan as of now is available with the Plexi Light that is there. And if you are predominantly trying to study about the choroid, then one would definitely look into the SSOCT. But apart from that, if you are trying to study about diabetic retinopathy or a vein occlusion, I am sure the SDOCT also is phenomenally very good. So now these are the different machines that are available. And now there are also protocol machines which are like going up to the depth of, but of course they are still in the research that goes up till 22 millimeters. So one day we are going to have an OCT machine which is going to give a study from the optic disc to the ora itself. So now this is how you get a TopCon and a Zeiss printout, and one should understand the segmentation. So segmentation, why is it important? There is the automated generated segmentation is there, and whenever there is a pathological entity, many a times one should also resort to manual segmentation. So you must pay attention to the segmentation, otherwise we may be ending up, dealing with a wrong understanding. Sometimes even a PED could be interpreted as an MNV. So these are certain things one should pay attention to. So the VR interface is the first one which you should see, where the segment has happened, and the superficial, the deep, the avascular, the choriocapillaries, capillaries, and the choroid. So as I had described initially, so the segmentation should happen at that particular location only. Now, how do we go about really doing this? So first, the clinical examination, nothing can go against clinical examination. You need to see which is the area of interest that you would like to do, and you will first see the NFAS image, see the structural component, see the vascular slabs, and pay attention to the segmentation, and then finally to the OCT scan and the flow signals. So this is how you must, see your or read your OCT. So now image the right spot, look at the NFAS OCT image, which you can see here. These are the NFAS images which comes first, and then look at the segmentation lines. So it should correspond to the anatomical structure where it should be, because in pathological thing there are movement of lines which can happen, so one should pay attention to that. Then look at the B-scan overlay which is there, and you should also look at the NFAS intensity image as well. That is a final one. So if you are wanting to read about OCT nomenclature, this is a consent-based recommendation. This article is good for all of you to go through. And you must understand that certain things in OCTA, certain words are not to be used, because people try and use, flow void and flux and things like that. But that is not the thing in OCTA. So what should be the words that should be used? Either you say the signal intensity is increased, decreased, absence, or present. This is how it must be. So now I'm going to show you OCTA picture in which you see there is a 6 millimeter by 6 millimeter NFAS SCP slab. You can see what I said, decreased signal. So when you say decreased signal here, so there is a non-perfusion, at the FASF. So now what does this actually mean? So when you have non-perfusion, you see that as a loss over there. So now in certain situations, what you can also see is there is some mild increase in intensity of the signal there. So when you see that, one should understand that there is probably something happening, that is vascular remodeling, or it could be a neovascularization. So when you see a structural OCT, so when you see an OCTA B scan here, now you kind of see this is at the boundaries of the MCP and the DCP. So in that, when you see a hyperreflective area, then that could be a sign of an intraretinal neovascularization, or even it could be a neovascularization in the MACTEL type. So now here, what are you exactly seeing? I have marked the circles which is the area of interest here. So what does it exactly see? So this is a superficial capillary plexus flap, and that you kind of see there is an increase in signal. So this, how do you know that it is a microaneurysm? That is basically because it is because of the location. So one can identify things on the basis of the location of the lesion. So now the next most important thing is also one should pay attention to the artifacts. So what are the artifacts that one should pay attention to? Because the time scale, I told you there is something called as a decorrelation signal. That is because of the time lag which is there. So when you kind of, take multiple images, there are a lot of artifacts that happens. So these artifacts are like motion artifacts, the projection artifacts, the segmentation artifacts, the suspended screening particles in motion. So we call it SSPM. So these are all the things one should concentrate on, the masking. So these artifacts, you should know to identify them. Otherwise it becomes difficult when you interpret. So now to say what I've shown it as a motion artifact, this is a blink artifact, and you also have a doubling artifact. So these are all certain artifacts one should pay attention to. Now, if you want, sometimes we do what is called as a DR protocol, where we try to stitch multiple images. So this is taken by, this is called montage, where you kind of stitch around 5 images together. So in these kind of protocols, you tend to have stitching artifacts. So this is something one should pay attention to. So now if you see, this is a plexilite image. So in that you have the multiple slabs which are shown, that is the 3x3, and then you have the 6x6, and then you also have the 12. So you can also have the 15x9 as well. So now, apart from that, you should pay attention to this signal intensity. Now you can see where you would like to see your signal intensity. If your signal intensity is somewhere less than 6 and all, it is not very acceptable. So that is called as image quality metrics. So one should pay attention to that as well, because if you don't want to have a poor quality image and then use it for reading. So now, why do we really need OCTA? So where do you actually require it? So most important thing is on patients whom you could not do an FFA for reasons like patient has got a kidney disease, you will not be able to perform an FFA. But believe me, OCTA is kind of replaced FFA in many of the disease modalities. Very few are the areas wherein one would require the use of FFA. But I am sure FFA is not going to become depleted. It's not going to go away, because it is still going to have its own use. So where does OCTA have its usefulness? It is a non-invasive detection, and it is useful in detecting the morphology of the MNV itself, and you can monitor the response. In diabetic retinopathy, very useful to see the FAZ enlargement, the capillary dropout, the neovascularization mapping. In retinal artery or vein occlusion, you could map the ischemia, the see for the collaterals and the new vessels, and uveitis or the white dot syndromes. You can detect the inflammatory CNV and the choriocapillary flow deficits. And of course, in glaucoma, you could see the peripapillary and the maculovessel density, and you could use in the inherited retinal diseases to quantify the microvascular loss. And now to show a few examples here, you can see this is a type 1 MNV, which you can see. So when I say type 1, it is, of course, it is beneath the RPE. And when you have the type 2, it is between the neurosensory and the RPE. And in the type 3, when you are seeing, you can see that type 3 is, of course, many times to be missed. It is just seen as a tiny bright area where you see that is what is most important, that is seen on the choriocapillary slab. And now about the choroidal vessels. So when you have the atrophy of the RPE, then you tend to see you can see the picture here. This is an atrophic atrophic RPE. So you tend to see more of the choroidal vessels. So don't think in terms of treating these patients, because you're actually seeing the hyperreflective choroid underneath, and no indication for an anti-VEGF. Now, moving on into what is called as an intraretinal microvascular abnormality. When you clinically see this image, all of us tend to think that probably we are dealing with a neovascularization. But what exactly is it a neovascularization? When you see these, when you see the slab, that's when you kind of identify that the VRI slab, or when you look through these things, you see the flow here. In that, it is not elevated. You see it within the neurosensory retina. You're not seeing it anywhere above the at the level of the VR interface. So that clearly it deciphers that we are dealing with an intraretinal microvascular abnormality and not a neovascularization. So when you talk about neovascularization here, you can see this particular patient, you can see the neovascularization, which is actually standing in front. But when you see the fundus photograph, all of us would predominantly miss it up if we are not carefully watching this. So, and in this patient, if you see very carefully, there is a tiny neovascularization in this patient as well. So now when you are talking about retinal venous occlusions, in occlusions, predominantly we try to observe the shunt vessels, which you see here, and the microaneurysms, which you can see, and also areas of the capillary non-perfusion areas. And in this, you can see the basically the volumetric analysis you can see, and of course on the B scan you can see the tiny cystic spaces that are there. This is a branch retinal vein occlusion involving the superior artery. So now when you talk about the FAZ, so when you see FAZ, you would like to see for enlargement of FAZ, or if you would like to know whether there's a stretch of the foveal vascular zone. And in these cases, it is pretty important that you see the vessel density, which is very much available, is parametric values. So that is pretty useful as well. And also you try to see whether it's a non-perfused or it is a stretched macula. So these are all the conditions one definitely would like to use. And in summary, OCTA is a pretty useful non-invasive tool, and it is useful in patients with comorbid conditions. And it is one thing that it is the most important thing one should understand, that it cannot detect a leakage. So you cannot use it in CSCR patients and try to do a focal laser. That is not going to be possible with this. You should understand the limitations as well. And it is an excellent device for monitoring, whether it is in macular neovascularization, or you would like to monitor an macular edema. And most important is to be cautious on the artifacts itself. So with that, I kind of conclude the talk on OCTA. So I would be happy to, take up questions.
I have a request, Dr. Suganeshwari. You people are international faculty. Everybody realizes that, but we will take questions after fishbowl, because all the retina people I am watching. So there are 52 people have joined by faculty link. And there are so many others also. So we will take questions later, because Dr. Shweta Walia has to go. She has small children. So we will take up questions later, Dr. Vatsala and all the PGs. So you will never get PGs like teachers like Suganeshwari, Poornachandra, Dr. Subina, but rarely you get such teachers. So आप लास्ट में आप लोग क्वेश्चन पूछना. अभी हम लोग फटाफट टॉक्स खत्म करते हैं और फिशबॉल शुरू करते हैं. आफ्टर फिशबॉल we will keep a discussion part.
Okay, ma'am.
Thank you so much, Dr. Suganeshwari.
Thank you, ma'am. Thank you, ma'am, for the excellent presentation on OCTA. Next, I would like to call Dr. Poornachandra. Now, Dr. Poornachandra has been with us with JHOS educative program for the last couple of years, and he has been excellently in describing the electroretinogram. That is his favorite subject. So, Dr. Poornachandra, please.
Thank you so much, Dr. Rahul.
क्या है, डॉक्टर पूर्णा ने अपना नया सीवी दिया है, तो अब ये बहुत बड़ा सीवी है, बट he has got best of IJO award, ASRS award, JOCR award, AIOS International Hero Award. Means he is the best international hero in retina. So a lot of international awards I can see. So it will take a lot of time. So we are proceeding to the talk.
Thank you, ma'am. Thank you so much. At the outset, I would like to thank Jharkhand Ophthalmic Society, especially Dr. Bharti Kashyap ma'am, for the opportunity. And thank you, Dr. Rahul, for the kind introduction. Hope my slides are seen in full screen mode. And
yes,
my voice is clear.
They are there. They are there. Fantastic.
Okay, fine. Excellent. Okay, so my topic will be, basics of electroretinogram. I'll keep it brief about the basics, followed by case example, which are relevant to every ophthalmologist. Fine. So full-field electroretinogram is basically a mass response of the retina to a luminance stimulus. Stimulate the retina with the light or what pattern. There will be biochemical and ionic changes which happens in the receptor P, which generates electrical potential, which is recorded as electroretinogram. Fine. So there are different waveforms in ERG. The way we have PQRS in ECG, something called A wave, B wave, and oscillatory potential in ERG. The first negative deflection is the A wave, and it is from the outer retina, that is photoreceptor. So followed by a B wave, it is predominantly from the inner retina, that is bipolar cells, with some contribution from molar cells. If you carefully observe the ascending limb of B wave, there are some deflections here. These are called oscillatory potentials, and these are from amacrine cells. So when it comes to ERG, whenever we consider doing an ERG, first we should know what test to order. Okay, because ERG just not one thing. There are different types. So full-field ERG basically it represents functional integrity of the entire retina. Pattern ERG is predominantly from the posterior pole. In multifocal ERG, as the name suggests, we check multiple points on the posterior pole, that is the macula. Right. This is how a typical full-field ERG printout looks like. will have a dark adapted response, which is recorded after 20 minutes of dark adaptation. So which basically, needless to say, it is predominantly a rod-driven response. Once we increase the stimulus intensity, there will be some contribution from cones also. So then we lighted up the patient for 10 minutes. In that, if you stimulate the retina with 3 candela per centimeter square, what we get is a predominant cone response. In the same light adapted state, if you stimulate the retina with 30 hertz flickering light, what we get is an the exclusive cone-driven response. So basically, we started with an isolated rod-driven response, and we ended with an isolated cone-driven response. So whenever we look into the ERG, we need to look whether the cone component is affected, a rod component is affected, or both are affected, or if there are any special waveforms. So let's try to jump into some of the case examples. So these are, as I keep telling, these are stories of different individuals. So this is one such story of 41-year-old gentleman who presented with, eye strain, burning sensation, light sensitivity, and I was diagnosed to have dry eyes and also, started treatment for keratoconus elsewhere. But symptoms persisted, it got never relieved, and he developed work-life stress, altered sleep cycle. So he changed workplace, switched jobs due to bright light. Finally, he had to consult a psychiatrist where he was started on amitriptyline 10 mg and also propranolol for anxiety. He had an associate hypothyroidism and hyperlipidemia. So obviously, because of all this stress, he became alcoholic and also smoker. So when he came to us, so we evaluated, there was no history of consanguinity or any other family members having any retinal issues. Basically, it was referred from refractive department because they clearly told there is no keratoconus or any dry eyes. Just you guys have a look at it if there is any retinal issue. So this was his vision and anti-segment examination profile. Vision was perfectly fine. So 6/6 sensitive, the color vision is also fine. So rest of the anti-segment examination was normal. So fundus examination, again, it was absolutely normal. So this is the bilateral white field of autofluorescence image, which is again normal. So for the sake of completion, we did everything. So the OCT that we did, which definitely appeared normal, but for me, in the right eye, in the subfoveolar zone, the interdigitation somehow it appeared little attenuated. So if somebody says it's normal, it could be normal, but for me, it looked little suspicious. So for the sake of completion, we did OCT angiogram, also the field test, which was not both 30-2 and 10-2. Then finally, I had to do an ERG just to be very sure that we are not missing. If you carefully observe this ERG, the bottom row represents the normal and the top two rows represent the recordings from right and the left eye. In this, the dark adapted responses are completely normal. If you look at the light adapted responses, there is 50% reduction in amplitude compared to the normal. So that means this patient definitely has something for which he's having this photophobia like symptom. That means he's not lying. This is not malingering. Okay. So far, he has been, visiting so many hospitals where he was told like everything is fine, everything is fine. First time we got an evidence that there is something wrong in the retina. So we went ahead and did multifocal ERG. Again, there was a reduction in central response, which was more in right eye compared to the left eye. So the pattern ERG was also telling the same story. The right eye seems to have affected more. Left eye was almost near. So now if you put everything together, the OCT change which is suspected and the corresponding light adapted response, the multifocal ERG, pattern ERG, everything fits in. So this is what basically, this is one scenario where we didn't give any treatment. We just told him that there is an explanation for your symptoms and patient was so happy. I just gave him photochromatic glasses and also gave a letter to the workplace, stating that he has some issues with the cone system because of which he is uncomfortable with the bright light and all that. So he's been following with us for more than 2 years and is perfectly all right. He's already off all antipsychotic medications and is leading a normal life. Okay. So, and we went ahead and we wanted to understand, we know the problem. No? What could be this? It could be anything. It could be atrophic macular dystrophy. It could be a variant of bone dysfunction. We also did a genetic testing. At this point of time, we are not able to pick any, mutation which can cause this, which can happen if there is any, very rare bone dysfunction syndrome. The present genetic system, genetic testing system may not be efficient enough to pick those. We are keeping him under follow-up. We maybe will repeat the test after 2 years. Coming to the second case example, this was a story of 17-year-old female who complained of deviation of eyes and safety eyes with photophobia It was noticed since birth, and she was using glasses regularly. She had a high frequency, low amplitude pendular nystagmus, which used to dampen on convergence. So this was a refraction. So the BCVA in right eye was 660, left eye was 6 by 48. So near vision was quite okay, but it was close to space. But if you look at the color vision, she was not able to identify, not even the demo plate on Ischiara. So the color vision was grossly abnormal. The fundus clinically looked normal. The OCT was also normal. For wide field autofluorescence was also unremarkable. So this was the posterior pole autofluorescence, which is again normal. So, but if you look at the ERG, as compared to the normal, the dark adapted responses, there is a cross reduction in B wave amplitude. And if you look at the combined response, that's something interesting is happening here. The A wave is forming here. The B wave is not even reaching the baseline. It's getting terminated here itself. So this is what we call it as classic electronegative ERG. This is seen in any conditions where there is an inner retinal dysfunction. And similarly, if you look at the photopic responses, so there is almost like 90 to 100% reduction as compared to the normative. So this is a very rare combination where you had features of both congenital stationary night blindness and also an achromatopsia, which is a cone dystrophy. So which is very important to understand. If not for ERG, would have missed this because structurally everything appeared normal. Fundus was normal, OCT was normal, and these patients have a very peculiar profile. So once they go to the dark places, they take extra time to get adapted. Once they go to the very lit places, they cannot tolerate the light. So we need to counsel them and then, suggest lifestyle modification accordingly so that their quality of life can improve. Fine. So next, coming to the next set of disorder, the bestrophinopathy, because I commonly, a lot of reference for these patients which get commonly misdiagnosed for some of the uveitic NCTs are pachychoroid spectrum disorders. That's why I thought of giving example of this bestrophin related disorders. So the first family was in the family A. The proband was 11-year-old male born out of a consanguineous marriage. He had a vision of 6 by 9. If you look at the fundus, there's a vitaliform deposit right over the macula, which can be appreciated better when we do an autofluorescence test. In the OCT, there's a corresponding subretinal fluid with subretinal vitaliform deposit. So when we did an ERG, it was completely normal. So if you look at the EOG, which is electrooculogram, so the light peak which was supposed to be present here like this, which was absent. So a normal ERG with an abnormal EOG, which is characteristic of a dominant basis. Okay. Now coming to the second family. So this was proband was a 25-year-old male. So vision was 6/9. So we had visited multiple, hospital. Finally, he was diagnosed as some posterior uveitis, had taken all kinds of immunosuppressants, antivirus, and all those things. But if you look carefully, so the vitaliform deposit, which was limited just to the macula in the first case. So here, if you see, the vitaliform deposit is quite extensive for the fingers. So if you, in the OCT, there were both subretinal and also intraretinal fluid. So FFA showed non-specific leakage and staining pattern. In the ERG, the EOG is grossly abnormal, but ERG was also abnormal. So this happens in case of recessive bestrophinopathy. I'll come to it later. So the third family had multiple affected family members, though the proband was a 21-year-old female. So this is the the color fundus photograph, the corresponding autofluorescence and OCT of proband. The first sibling, the second sibling, and the third sibling, all of them had more or less similar pattern. The vitaliform deposit pattern, fell somewhere between the dominant and the excessive disease. So why there is so much of difference, in all this family? So the reason being, the first one is a dominant test due to heterozygous mutation bestrophin gene. So the latter two are recessive test. Again, there is a difference. One is homozygous mutation bestrophin gene. The second one is a compound heterozygous mutation. That means the mutation at two different locations. So this is an example for, typical example for how, the gene could be same, the inheritance pattern could be same, but the clinical manifestation could be little different. Okay. Unless we know this, we may miss this and we may mistakenly treat this disorder for something else. So to conclude, I would like to show all these three images. If you just observe in the first image, there is a mild skytic changes, which is more in the second one, and third has a subretinal fluid. This looks like maybe spectrum of pachychoroid disorder, but it's not. The first case, when we stimulated the retina for long and medium wavelength zone, it was undetectable. When you did When we tested for sharp wavelength cone, there was an exaggerated response. So this was a case of enhanced response syndrome due to mutation in NR2E gene. The second case is a case of juvenile retinoschisis, which had a typical electronegative ERG due to inner retinal dysfunction. The third case is one of the cases which I just showed in the example. This is a recessive base due to homozygous pest mutation. So that's why once you put everything in the context, the things become very clear. You should not take any investigation in isolation. I would like to end by what my mentor taught me in more fields. Do not fit electrophysiology into clinical diagnosis, fit clinical diagnosis into electrophysiology. Thank you so much.
Thank you, Dr. Poornachandra. It was excellent. And it is always a learning experience, the way you present your slides on complex subjects such as ERG. It's always a learning experience.
Yes, truly. So next speaker, there are so many people who want to discuss, but we will take discussion after fishbowl.
Sure, ma'am. Sure. So I would like to call our last speaker, Dr. Pratyusha, who will be talking upon FFA.
Good evening to everyone. Let me just share my screen. Are my slides visible?
Yes, they are, Dr. Pratyusha.
Okay. At the outset, I'd like to thank Jharkhand Ophthalmological Society and Dr. Bharti ma'am for giving me this opportunity. So the topic that's been allotted to me today is Fundus Fluorescein Angiography, the basic principles and interpretation. So I believe majority of the audience here is postgraduate students. So I think I would just stick on to the basics of fluorescein angiography and how we will interpret fluorescein angiogram. So all of you must have seen a fluorescein angiography being performed in your institute, right? So I will not go into the details of how a fluorescein angiogram is done and the theoretical aspects behind it. So we all know that sodium fluorescein is a molecule that basically responds to light energy between 465 to 490 nanometers and fluoresces at a wavelength of 520 to 530 nanometers. So basically, we are sending blue light, which goes through through the blue excitation filter, strikes the retina, and as the sodium fluorescein dye circulates in the retinal and the choroidal circulation, this dye gets excited and then emits the wavelength of light in the yellow-green spectrum, and this is caught by the detector. So when we do a normal first we should understand what is a normal fluorescein angiogram before we go into abnormal fluorescein angiograms. So I'll just show you the various phases in which the dye circulates in the retinal and the choroidal circulation. So after you inject the dye, after about 10 to 12 seconds, you can see this kind of a picture, which is basically what we call as the choroidal flush. This is nothing but filling up of the choroidal vessels. The long ribbon-like structures that you're seeing here are the choroidal vessels. The dye gets into the lobules, the choriocapillaries, which are arranged in lobules, and it creates this choroidal flush. You might be also noticing this retinal vessel getting highlighted here. This is the cilioretinal artery, which also fills up with the choroidal circulation because its origin is from the ciliary arteries. So the dye first reaches the ciliary arteries and then it reaches the central retinal artery. So after about a couple of seconds after the choroidal flush, we see something like this, where the dye starts entering into the retinal artery. And this is the arterial phase of the angiogram. The blood flows through the arteries, through the precapillary arterioles, into the capillaries, and then it goes through the precapillary venules into the veins. So once the veins start filling up, we see this arteriovenous phase, wherein the dye is actually concentrating on the walls of the veins. So this is something called as a laminar flow of the dye in the veins. And this, when you see a picture like this, you're reading an angiogram in the arteriovenous phase. And then we have the next phase. That is, here you can see that the veins are now completely filled and the concentration of the dye in the arteries and the veins is almost equal now. So this is the early venous phase. And then the dye slowly starts washing out of the arterial system, and it starts, and the veins start becoming appearing brighter. So this is the late venous phase, which normally is about 10 seconds after the arterial filling. And then as the angiogram proceeds, we have the recirculation phase and the late phases, wherein slowly the dye is getting washed off both from the retinal and the choroidal circulations. But what you need to observe is this staining of the optic nerve head, which happens as we reach the later phases of the angiogram. So if you are asked to read an angiogram and you need to understand which phase it is, kindly look at the disc staining. This disc staining happens in the later phases of the angiogram. So this is an even later phase where you can see prominent disc staining with almost no dye in the blood vessels. So I'd like to draw your attention to this particular, structure. This is the foveal avascular zone. So when you look at a fluorescein angiogram, you can see this kind of a cobweb-like appearance around the fovea, which is the foveal avascular zone. Now this has to be intact. The size has to be less than normally about 400 microns. So it has to be of the adequate size, and the margins or the continuity of this retinal capillaries, perifoveal capillaries, has to be maintained. And then we call it as a healthy foveal avascular zone. So this becomes very important when you're dealing with cases of macular ischemia where the foveal avascular zone may be disrupted. So, now today with the advent of OCT and OCTA, which Dr. Suganeshwari ma'am very nicely presented, the indications to do fluorescein angiography, the dye-based fluorescein angiography, has drastically reduced, but it still has its role for two reasons. One thing is, of course, as madam said, the leakage component cannot be made out in OCTA, which you can make out in fluorescein angiography. And more importantly, OCTA is a luxury, and it is available only in certain institutions, probably in the top 10% of the institutions that are available in our country. And most of us, if you're retina practitioners outside, we still have a fluorescein angiography, an invasive fluorescein angiography, because the investment for OCTA is quite high. So when we interpret in fluorescein angiogram, we normally use these terminologies. One is hypofluorescence, and the second one is hyperfluorescence. So hypofluorescence is of two types: filling defect and block fluorescence. Hyperfluorescence is autofluorescence, pseudofluorescence, transmission defects, leakage, pooling, and staining. So let's see all these with examples. So this is a patient who had a massive retinal hemorrhage. There are various levels of hemorrhages here. If you see, there's a subhyaloid hemorrhage, there is a subretinal hemorrhage, and there are intraretinal hemorrhages. So when you look at the corresponding fluorescein angiogram, you can see that this whole area is dark, which is hypofluorescence. But this is a kind of hypofluorescence basically because something is blocking the fluorescence from reaching the detector. So this is called as a blocked fluorescence. So this is blocked retinal. This hemorrhage is blocking the retinal and the choroidal fluorescence in this angiogram. So we have another example here. There is hypertrophic retinal pigment epithelium, and when we do an angiogram in this condition, you can see that the retinal circulation is well seen, whereas the choroidal circulation is masked, or it is blocked. So this is blockage of choroidal fluorescence due to a hypertrophic retinal pigment epithelium. The next type of hypofluorescence, as I said, is the capillary non-perfusion. Capillary non-perfusion, as the term indicates, it means that the blood is reaching the arterioles, but it is not getting into the capillaries because the capillaries are blocked. So various vascular conditions like vein occlusion, stablic retinopathy, retinopathy of prematurity, all of them ultimately manifest as capillary non-perfusion areas. And when you look at these areas, which are normally supposed to be perfused, you're seeing no signal. I mean, you're not seeing any fluorescence over here. So that is why we call it as capillary non-perfusion. Another example here, it's a branch retinal vein occlusion. So if you see the normal, between the arterioles, you should have this kind of a, is my pointer visible? Dr. Rahul,
is my... Yes, ma'am. Yes, ma'am.
Yes, it is visible, and it is very interesting.
Thank you, ma'am. Thank you. So if you see this kind of between the vessels, the arterioles, or the you should see this kind of fluorescence normally. But if you look at this portion where there is a branch retinal vein occlusion, you can see that there is no perfusion here. So these are called as capillary non-perfusion areas. Okay. So now we move on to hyperfluorescence in a fluorescein angiogram. So if you look at this picture, you can see that the optic nerve head is actually hyperfluorescent. So this is because it is having optic nerve head drusen. Now, these drusen actually don't require sodium fluorescein to emit fluorescence. So you just take a pre-injection photograph, and you will realize that the fluorescence is already present. So this is called as autofluorescence. And some of the lesions which are known to cause autofluorescence are, we have optic disc drusen, astrocytoma, and so on. The actual hyperfluorescence that we are talking about now is hyperfluorescence due to transmission defect. So what is transmission defect? Now, if you look at the color fundus picture over here, you can see multiple areas of retinal pigment epithelial atrophy. And this is a patient basically with dry AMD. So if you see the angiogram, if you follow the angiogram of this patient, you will see that the hyperfluorescence is increasing. The brightness is increasing and decreasing with the choroidal fluorescence. That is, as the choroidal fluorescence is increasing, the angiogram is appearing hyperfluorescent and then it is decreasing. So it is basically nothing but transmitting the choroidal fluorescence through the defects in the retinal pigment epithelium. This is a diabetic retinopathy patient. You can see multiple microaneurysms, cotton wool spots, dot blot hemorrhages, and so on. So if you look at this angiogram, you'll see these multiple hyperfluorescent lesions, which are nothing but the microaneurysms in the early phases. And if you see the later phases, you can see that that distinction as individual white spots is gone, and now it's become sort of a smudge, although you still can make out some microaneurysms. A lot of these microaneurysms have become a kind of a blur with a smudge. This is because the dye is leaking out of these microaneurysms into the retinal tissue, and this is what we call as leakage. So there's another type of leakage that happens in central serous retinopathy. I will come to that a little while later. Then there is what is called as pooling. So what is pooling? Pooling is basically accumulation of the sodium fluorescein dye into a confined space. For example, a serous PED, a pigment epithelial detachment, or it could be into the subretinal space, as we see in central serous retinopathy. So there is a leak here, and that is going and filling a cavity, and that cavity is what we call is what we are seeing as pooling. The third type of hyperfluorescence is staining. So in staining, there is some abnormal tissue which is actually capturing that sodium fluorescein, retaining that sodium fluorescein throughout the angiogram. And so what is happening is this intensity of the dye is increasing as the angiogram proceeds. But the size of that, that lesion is remaining the same. So this is a disciform scar in wet AMD. You can see that the dye is progressively accumulating in this abnormal tissue. That is, it is getting stained. Okay. So as I said, the indications have drastically reduced, but still it has a role. So in diabetic retinopathy, one of the commonest things I think all of us will see in our retina practice, what is the role of FFA in the current scenario? Of course, it is to identify macular ischemia. You're giving anti-VEGF injections, macular edema is reducing, but the patient's vision is not improving. So that's the time when you want to think and, you want to really look for macular ischemia. And that's where fluorescein angiography will really help. The second thing is when you're trying to distinguish intraretinal microvascular abnormality from a new vessel. Okay, so I'll show you an example. So for example, if you see here, this is a patient who had a little bit of a cataract. We could see that definitely severe NPDR findings are there in the fundus, but we really could not pick up a new vessel in this patient because of the thick cortical cataract. So we went ahead and did a fluorescein angiogram. You can see these areas, again, capillary non-perfusion. Pay attention to these kind of vessels which are there between the arterioles and the venules. These are the intraretinal microvascular abnormalities or some kind of abnormal vasculature in diabetic eyes. So this was something that was seen throughout the fundus. Of course, the microaneurysm related leaks are there everywhere. But do you see this portion? This portion, there is an intense leakage that is happening. This is a new vessel. So this kind of a leak which happens only in new vessels. It doesn't happen in intraretinal microvascular abnormalities or IRMA. So this is where fluorescein angiography plays a very, very important role. Okay. So in vein occlusions, again, the indications are almost the same. That is, if you want to look for macular perfusion and if you want to distinguish collaterals from new vessels. I'm sure a lot of you would have seen these kind of, vessels on the disc, and you're always confused. Wait, am I dealing with neovascularization of the disc, or are these optociliary shunt vessels? So optociliary shunt vessels commonly be seen in central retinal vein occlusion. So when you have a doubt, now these are very typical cases, so we can probably even with clinical examination, you'll be able to make out, but sometimes the differentiation becomes a little ambiguous. So when you do a fluorescein angiography, you can see that an NVD leaks profusely, whereas optociliary shunt vessels don't leak. So this is where in vein occlusions, the angiograms can be useful. Then, of course, in retinal artery occlusion, it's mostly a clinical diagnosis, but sometimes rarely we might need to do retinal fluorescein angiography. So if you look at this picture, this is a classic cherry red spot, what we describe for central retinal artery occlusion. And if you look at the angiogram here, even after 33 seconds of starting the angiogram or injection of the dye, the dye has not reached the arterial circulation. So this is what we call as a delay in the arm retinal time, right? So as I said, CSR again. So there are two kinds of hyperfluorescence that are happening here. One is a leak. Now this leak is going to collect, this dye is going to collect in this pool of subretinal fluid, and that so there is both a leakage as well as a pooling which is happening in this particular condition. So this is the classic smokestack appearance what we all read in our textbooks. There is another kind of leak that happens in CSR. This is again subretinal fluid in this region. Angiogram showing a small hyperfluorescent dot, which as the angiogram progresses is enlarging in size and intensity, and this we call as an ink blot leak. So of course, in dry AMD, we don't need to do a fluorescein angiogram, but I'm just showing you how it would look if you would do it. So these are drusen, which are showing staining, whereas this is RP atrophy, which is showing window defects. So you can see in the same dry ARMD, you can have different patterns when you do a fluorescein angiogram. So again, for choroidal neovascular membranes, we no longer need to do fluorescein angiography in every case, but this was during those occurred CNVM. So classic NVM classically described as a lazy pattern of hyperfluence which leaks in the phases. So it's this black thing. So you might ask, what is this black thing? It's difficult for me to tell, what is this black shadow over here? So always remember, interpret a fluorescein angiogram of beginning to leak from, and we have fibrovascular PD, there is pigment epithelial detachments. The other place where FFA really helps is in distinguishing BKH from a multifocal CS, them present with multiple pockets of subretinal fluid, and you don't know what you're dealing with because one needs to be treated with corticosteroids. In that case, you have to completely avoid corticosteroids. So that's where you do an angiogram and you will see these multiple pinpoint leaks at the level of the RPE, and very importantly, this disc leak, which is characteristic of Vogt-Koyanagi-Haida syndrome. And in certain choroiditis, it helps you assess the activity of the choroiditis. For example, this is a patient with right eye active choroiditis and left eye an inactive scar. So the scar basically only accumulates the dye, that is basically it gets stained. Whereas, this is a patient with, you can see this edge, which is having this kind of a leakage or some smudge going on here. So this indicates that the edge of this lesion is still active. So these are just a few examples of where we use fluorescein angiography in the real world. There are a lot of advances in fluorescein angiography because it's more than 70 years old now. We have wide field and ultra wide field angiography where almost up to 200 degrees of the retina can be captured in a single frame. We have video fluorescein angiography and also RETCAM FFA. RETCAM is especially useful in babies with retinopathy of prematurity. So with that, I come to an end. Thank you all for your patient hearing.
Thank you, ma'am. Thank you, ma'am.
So please stay with us because thank you so much. And actually, I realized this gravity of this session because for 20 years, I was practicing medical retina in my hospital doing barrage laser, FFA, OCT, PRP. So I understand. And I realize, and I think the PGs, they will all come again for discussion, and the junior young retina specialists have also joined. Dr. Ritika, Dr. Archana, Dr. Divya. So